Uh, Welcome to this last session. I know all of you have had an overdose of healthcare over the last 2 days, and it's time to probably now go home. But we thought that we won't let you go home before some new ideation. What use is sitting over here for the last 48 hours and going back with the same thought process, with the same thinking, with the same mindset, and saying, oh, it was just the same all over again? So it's time to do some rethinking. It's time to reboot our heads, time to get the gray cells going all over again. And it's time to probably look at what India is doing best right now, which is creating the opportunity to create new businesses, new idea, disruptive new innovations, and basically let every sector in this country gain the momentum of this new opportunity. For a very, very long time, and rightly so, market forces have not really been at play in the healthcare delivery sector or in the healthcare sector overall. We've all had a great opportunity in this country that the market size of this country gives us the opportunity to keep on doing the same and still growing. Right? But as you can see around you, and I don't know how many of you read the Economic Times this morning, but Zomato raised another $80 million. And what is Zomato? For all of us who've used Zomato, we would say that this is common sense, right? What is it doing? It's just giving me the opportunity to understand which restaurant I can go and eat what. And they raised $80 million. Every day, we find the startup ecosystem in this country raising so much of venture capital that all of a sudden we have begun to think that probably capital is coming for free. But it's not so. Because a lot of this capital is actually going behind making complex things simple. And healthcare has actually not learned how to make complex things simple. We believe and we revel in the world of complexity, and we keep on making it more and more complex for ourselves. So when we actually began to think through, when we were all of us were sitting together in the committee and thinking of what we should do to really create a difference in this conference, we felt one of the big opportunities that we had was to bring up front over here on this panel some of the breathtaking new ideas that are happening in healthcare that many of us don't even know and think about at times because we are so enamored in our world of large-scale healthcare enterprise that we seldom look at where new innovation is coming. And most often than not, if you understand the rules of disruptive innovation, and there's a great professor of mine by the name of Clayton Christensen, who actually said that disruptive innovation happens when you least know it. And it comes and takes you from the side somewhere, and you don't know what really hit you. And you ask everybody in the retail world today, and they will tell you about what disruptive innovation is all about. So the new heroes of today are the people who have created new business models and have created great innovation in the way that they're looking at their businesses. And all of us have begun to revere this new leadership which is happening in this country, where all of a sudden 35 some odd people and less than 30 years of age and about 35 years of age have actually become the new heroes of corporate India. So therefore, it's time to sort of think new. It's time to start thinking if the Bansals could do it with Flipkart, if Kunal Bell can do it with Snapdeal, if Paytm can happen with Vijay Bhaskar Sharma, then what is so great which is happening at Forus? What is so great which is happening at Neurosynaptic? What is so great which is happening with Embrace Innovations? And what is so great which is happening in the healthcare ecosystem today, which all these companies have created, which is actually going to blow all of us away in the next couple of years. So this session is about the new healthcare for the new India. And this healthcare session is going to be about where disruptive innovation in healthcare is happening and how these new companies are changing the old order and bringing the new in and bringing it so fast in that over the next couple of years, we will see a totally new healthcare delivery ecosystem in this country. And for many of you young minds who are sitting over there, many of you will get some new ideation over here. And guess what? There'll be many of the venture capital funds who are sitting outside of this room who will come and tell you, here is another check for $1 million, and go and make your idea happen. Right? So let's celebrate the startup ecosystem in healthcare for India. And I leave it now to Vijay Simha to moderate this session. And he himself is an innovator. So here is to some celebration of innovation.
Thank you, Vishal. We are extremely honored to be here and to be able to present some of the ideas that we have. Some people call us crazy, some people call us whatever names they can, but the idea here is, as Vishal mentioned, is to make complex things simple, to make things easier, affordable, and probably we have to think completely differently. One of the biggest challenges in Indian healthcare, and when we look around us and we talk about problems that afflict our rural healthcare, where access is not easily available, and new ideas like telemedicine and new ideas like I would say hub and spoke models have been replicated across. Um, there are other factors which need to be, or gaps that need to be bridged, which so far, the traditional technologies that exist around are not useful to us, for the simple reason that the milieu that exists in the more developed countries, where logistics and transportation and communication is much more, I would say, well developed in some cases, and the availability of number of skilled people to the people who need those skills, the ratio is probably much lower than what it is in countries where these resources are very limited. It becomes a challenge to use some of those tools to be able to use it. Simple examples we've been giving over the last 3 or 4 FICCI Heals was, of course, cervical cancer, breast cancer screening, which is so difficult to carry out because we don't have the right tools with us. So I would like to start with a little clip which talks about disruption and what it has been achieved. Over the last 3 years, we've had presentations from large, very ambitious ideas of how healthcare can be disrupted. 2 of them have now gone to the market, have been approved by the US FDA through a very lengthy process of PMA, and are in the process of being rolled out. They have already got their first customers. So the objective in this session, where we have looked over the last FICCI Heals at the startup desk, if you can call it that way, has been on how do you actually manage a startup going up to prototypes and getting your first customers. But what we have here is a bunch of entrepreneurs who have very, very disruptive innovations in their portfolio, and we'd like to listen to them more like a storytelling session where they actually explain how they moved from getting their first initial customer adoption to actual scaling up, which is something that people don't realize is probably the largest value of death in the entrepreneurship cycle. Disruptive innovation is not something that is adopted instantly, obviously. So you have a different mindset which brings people to adopt the new technologies. But then getting scale is a completely different ballgame altogether. It's not that the practice would be viral in any way. So we look forward to hearing from them. But before that, Vishal, with your permission, I'd like to play a small little clip which talks about the 2 previous innovators who were here in FICCI and what technologies it brought. And it's doing a lot of wonders across the primary care activity. And a little clip of Professor Christensen, who talks about, where do we look for this disruption, right?
The challenge that we face in healthcare, that is, we wish it were more affordable and accessible and higher in quality and effectiveness, isn't a problem that's unique with healthcare. Literally every industry in the world has run into these problems at some point in the past. But there's another type of technology that we call disruptive technology. And we use the word disruptive not because it's a breakthrough improvement, but rather it changes a product that is complicated and expensive into something that is affordable and simple. And what we found is that on this dimension of innovation, almost always, the leaders here miss this, and it's entrants that come in to make things affordable and accessible. So, how would you get healthcare affordable and accessible? But rather what we have to do is disrupt them by making things affordable and accessible so that larger populations can have access to better care, not worse care.
Cervical cancer is a major burden in healthcare resources. Over 500,000 women each year are diagnosed with the disease, and 300,000 will die of the disease.
Time is right to try and transform the way cervical cancer testing is performed, and Zillico is perfectly positioned to do this.
Our first flagship product is Z-Scan. It's positioned within colposcopy. So this is after a woman has had a smear test, and if that is, if they find some abnormal cells there, then the woman's referred to colposcopy.
So what is electrical impedance, and why is this such a breakthrough?
My background is into the electrical properties of tissue and goes back to about 1981. I developed a technique for imaging the resistivity of tissue.
2013 was a pivotal year for Zillico. Our flagship product, Z-Scan, got its regulatory approval in September 2013, and in October, we launched the product. One mustn't forget the emerging healthcare systems coming through India, China, Russia. They do, unfortunately, suffer from the highest incidence of cervical cancer. The biggest issue is because of the size of population and the lack of infrastructure, getting women to screening programs is very difficult. Z-Scan and EIS really come into its own in the emerging economies.
And there are other opportunities to exploit this technology.
We've just done a proof of concept study on 50 patients for oral cancer, and that data has been presented, and it's very impressive. We've got other products in the pipeline around anal cancer and esophageal cancer as well.
The Diansys Ansyscope monitor with AnsysStem provides objective scientific monitoring to improve P-stem therapy and enhance the opportunity for cure. Chronic pain affects 116 million Americans. That's 1 out of 3 people. More than the total affected by heart disease, cancer, and diabetes combined. Ansyscope from Diansys can read this sympathetic information as shown in the display. This information is critical to effective therapy, especially while using P-stem. The human auricle is a pressure point map of the human body. With the help of reflex points on the ear, it is possible to exert a selective effect on organs or regions of pain. After multiple treatments with AnsysStem, the patient's autonomic nervous system response will move towards the parasympathetic, which promotes body relaxation and pain reduction. In most cases, prescription drugs, which only mask the pain, can be greatly reduced or eliminated. P-stem therapy is effective for all cases of pain where vagal stimulation is recommended. Weighing just 7 grams, the appliance is very comfortable and allows free mobility.
So these products probably you will see very closely around the corner, and I'm sure that these products are going to be money spinners for the investors into these companies, because these are addressing very interesting areas where today we have very little solutions, expensive solutions like people overuse tramadol and overuse NSAIDs and have consequences which are pretty drastic and such. So if you see some of these technologies around, please do remember that they in some way started through the platforms at FICCI here. I would like to call upon Sham. Sham is an old friend of mine. Started for us about 4 or 5 years ago. Maybe he would be better introducing himself, but more than anything else, he's probably one of the most energetic and the most prolific thinkers on what are the problems in the Indian healthcare system. And he has come out with a series of products, not one, but a number of them, for which seem to be coming out of his stable like goldfish, excreta, one after the other. So I guess I will hand it over to Sham, and he will talk to us about what he feels were the challenges that he faced while crossing this chasm of death.
Thanks, Vijay. Thanks to FICCI and thanks, Vishal, for getting this opportunity. It's great that, we presented for us around 3 years ago in the same platform. And today we are very proud to say that, we have 6, that day we had only 1 product. Today we have 6 products in our pipeline. And we have already put them in the field. So Forus is a company where we said that let us do something for us. It's not for someone, All the while in my life, I've been working for multinational companies like Ericsson, Philips, and all that. Most of the time, we were only told that, well, we should think of the Japanese customers or the American customers or European customers, and we made everything, for that market. But then when you reflect and see what are we doing, at the end of the day, hardly 4 to 5% of our population can really afford that. So we said, okay, let us do something for us. And that's how, me and a couple of my friends got out of Philips and started this company called Forus. Before I get into the real Forus part, I thought that I just take the opportunity to see what is this disruptive innovation and new age entrepreneurship, the central theme for the session today. And so from that point, if you see innovations, basically there are 2 different type of innovations. Most of the time, we look at innovations purely from an incremental point of view or continuous point of view. That is, say, you get something, some product you take, reduce the cost or increase its performance or something, and then we put it into the market. That's something which is basically incremental innovation. And the other type of innovation is the disruptive innovation. That is the one which is discontinuous. And if we need to do something which is really going to be, what Vijay says, the earth-breaking ones, it has to be a disruptive innovation. And if you take some examples, like for example, you have diesel car. If you think of continuous innovation, you may come up with a better mileage car. But if you want to think of something which is disruptive in this segment, you may say it's electric car. So you see that's something different. So what is different here? You see that electric car, yeah, it's fantastic. If it can give the same sort of a performance and all that, you see that the price is very low and it's also very convenient. But then the way you are going to use the electric car is very different from the way you are going to use a diesel car or a petrol car, right? You take another example. I don't know how many of you youngsters have seen this. It's called as a VCR. Okay, these used to be, some sort of a gizmos in our houses. See, it's already gone. And if you take these VCRs, they're programmable VCRs. Okay, and we add some remote control to it because I'm talking from my Philips days. We add remote control. Then that's the incremental innovation. What is disruptive? The one what you see today, the set-top boxes. That's a disruptive one. So you don't need to worry about, the tape, whether it is rewound, all that stuff. You just have to push a button, record, and then it records. You don't know where it records. It's somewhere maybe in the cloud or it's in the back office of your cable operator, and then you can view that whenever you want. So the same concept if you take for a bypass surgery, and it could be, an incremental innovation is a beating heart surgery, maybe a minimal invasive surgery or something like that. But then if you see, there are disruptive in that, that is a cath lab or a catheterization. That is something totally different, because then you need a new set of people, new breed of doctors, new training. A person who does a bypass surgery obviously may not do intervention. Okay, so that's a different thing. So that needs a new infrastructure, new type of cath labs or OTs, and a new training, capacity building, everything. So that is the thing. And but if you see the advantage of this, it's enormous, right? That is the thing. Let us go for healthcare, basic healthcare. What could be incremental in healthcare is maybe hospital on wheels or something like that. That's again, it's one. But then what we are all talking about for the last 2 days, preventive care, it's a disruptive one. So what we see is that these are the big challenges and the paradigm shift, I would say, and discontinuous innovations. They require the change in behavior of the user. So that's the fundamental thing. The way you're going to use is going to be very different. The way you're calling taxi is very different after Uber has come in, right? So the way you use the taxi is also become different. The way you pay has become different. So these are some things, which are very, very disruptive. And what you see is the traditional way of marketing, traditional way of go-to-market strategies, everything, will go out of gear. And that is a very important aspect what we need to understand. Going by, the advantages of this discontinuous innovations, you see that there are continuous innovations have proven benefits. Okay, you can again count the IRRs and all that in a standard way. You have existing infrastructure can be used for that. And if you talk about hospital on wheels, existing infrastructure could be used on that, right? And old power structures, okay, you may have a outbound team or something, and they are the ones, who may take this out, and then on rotation, you may have them. But then if you talk about a total disruptive innovation, then that has new benefits. There are a lot of, it opens up a new market altogether, a total virgin market, which is untapped. And that's where, you see there's a lot of money. And there is a need for new infrastructure, no doubt. And then you need new power structures. And discontinuous innovations are at a very high risk also. There is something, the investor community should know. And then this will foster new powers and new structures, provided, it gets accepted. Okay. That's the risk. And based on that, Jeffrey Moore, who is another guru in high-tech product management, and this Jeffrey Moore, who is in the Valley, he has been seeing all the new generation companies coming up and .coms and all that stuff. Then he wrote this concept, and this was called as Inside the Tornado. That's basically today the time to market has reduced, the market windows have reduced, but then when a new innovation comes up, it catches up so fast that you just can't imagine. That is what we call it as tornadoes. Okay, and in this, the whole idea is that the way you bring in a product, you see if you see the bell curve itself, you can see that you can imagine that this is the size of the market or the business. The way it comes in itself, first you have innovators who come up with some ideas, then you have some early adapters. That is where, in healthcare, we need early adapters. The early adapters are the medical professionals, and they, some of them, are very tech savvy, and we need to get such people, okay? And then they may adapt this also, but then the big problem is, how do you scale up? That is where a lot of us, a lot of my friends who are in this business of startups and all that, we struggle because we don't know how to cross this chasm, because the next guys where there is a volume which is more than 1/3 of the market, that is the early adapters and early majority. And this early majority is something which is full of pragmatists. And these pragmatists come with a different mindset. And until unless they adapt your product, it's not going to take off. And tornadoes are not going to be created. And that is where, we see that that is the big leap we need to take. And that is when the scale up things come into picture. So as there is a difference in this whole game, early adapters don't easily, become the references for your technology. They, even if they are called as references, the pragmatists won't accept them. Okay, because they say, yeah, he's a tech savvy doctor. He almost buys any gizmo you come up with. But then what we need is a mechanism by which we enter the pragmatist market. And if we can't, then we are going to fall through this chasm. And that is what happened to several technologies in the past. You might have heard of ISDN. You might have heard of workstations. Earlier we had something called as workstations, sun workstations, and all these sort of things. All these technology, nice ones, nice fancy ones, even fax to that extent, have all fallen into the chasm. Okay. So now, what are the strategies, by which we can cross this chasm? And that, I would like to correlate with the products, what we do, and how we are trying to overcome this problem. So what is important is you have early adapters. Early adapters are those, for them, you don't have to sell a product, you have to sell a vision, okay, a concept, and then they buy in for that. And then you have the pragmatists. These pragmatists, they need a complete and tailored solution. They need total solution. I cannot go to them and say, well, this clinical trial is not done, will you buy this? No, they say, get lost. You come after the clinical trials are over, regulatory, everything, that sort of a thing. And they need to know exactly, how this is going to work, which segment I'm going to have, how much I'm going to charge, everything, that sort of a thing. That sort of pack has to be made. And then, we have the mass market, that is the mainstream, and where, we have to, they only buy when there is no other option. So it is obvious that, you need to create that demonstrate that marketplace dominance, and then through that, the mainstream people buy this. So what is important is that at the end, you have to think about the end user experience rather than thinking about just a product. So even if I'm making a small little product, that is what we see, amongst all of us, that's what we share. Even though we are making a small little gizmo, but that satisfies a complete solution and it's a total service. And at the end, it is the end user's experience which matters. Okay. And so this is a big adaptation what we need. And let us see how this we did in Forus. In Forus, we said, okay, I am sure, a lot of you heard yesterday Dr. Usha Kim talking about eye problems. In India, we have roughly 200 million people who need some or the other form of eye care, and we cater to just 10% of them. So there is 180 million, sitting there. If there is a way by which we can reach out to them, even if you make 1 rupee per person, a year, it's a huge money. But then, what is lacking? Basically, that is what we need to see. And what we did is in Forus, we went to this segment and we said, okay, let us see what is being done. How can I move the hospital to the patient rather than his patient coming to the hospital? So if you see, if you want to do that in eye care, there are different type of problems like any other ology. And here you see, most of the time, what we do when we go for a camp is basically you're just looking at some very, very simple problems like cataract and maybe at the most refractive errors, because that is what used to be done, in most of these things until and unless we came up with some disruption there. So we said that, okay, let us make a device which can do all the tests, test the cataract, refractive errors, also, look at the retina, and retina is a fantastic biomarker through which, we can check for chronic problems of the eye, like diabetic retina, glaucoma, macular degeneration, all these sort of retina pigmentosa, whatever, all sorts of these chronic problems. And then, then these people can be referred to the base hospital. But then if you go to an eye hospital, you see that there are so many different gizmos they use there. And the OPD of the eye hospital is the one, which is the largest. And there you see there are different type of technicians, a different type of people, a slit lamp. First when you go, they put you on a slit lamp, look at the anterior part of the eye, that is the cornea, and see whether there is any cataract or there is any keratoconus or infections and all that. Then, you are moved to the next device, which is basically a autorefractometer, and then they do the job of there's an optometrician, another trained technician who is going to do the job of looking at the eye and seeing what type of whether you have myopia, hyperopia, whatever. And then there is a nurse who puts an eye drop that will dilate your pupil, and then you are made to wait for half an hour at least, and then you are put on another type of a device which is called as a fundus camera, okay, a retinal camera, and then that is the one which will allow them to see the posterior part of the eye, okay, the retina, and that is imaged by a retina specialist again. This is another type of fundus photographer, we say. And then they also look at the intraocular pressure through a non-contact tonometer, and then that is something which is used for glaucoma. And then you get all the data from all this, collate them together, maybe a EMR or whatever, and then the ophthalmologist will be in a position to consult, or counsel. So this entire thing, if you want to do in a field, it's going to be a real difficult task. Not that this has been not attempted. In fact, yesterday, we also saw how Arvind Ai was trying to adapt this. But then what we did is, we said that, okay, one of the problems what we see here is the end user experience. What I mean by end user experience is that you dilate the pupil. The moment you dilate the pupil, the person has to wait for at least 3-4 hours in the hospital. And that is going to be difficult for the people, in the rural area, because most of them are on daily wages. So that day, they're not going to work. Even in the cities, it's a very difficult thing, Nobody can take half a day off just for getting the eye tested. That's what was the thinking, right? And if you see that all those who are diabetic, need to get their eye checked, at least once in a year. So these are very simple things because of this problem of dilation, waiting, going to an eye hospital, all these, was very cumbersome. So what we did is, the first thing we said is there a way by which, these are some of the statistics, like, the cost and all that, okay? And is there a way by which, we can remove this procedure of dilation? So we did a non-medratic device, which of course is not a big innovation. There has been this incremental innovation, because there has been non-medratic fundus cameras, but then they were not taken seriously because the image quality and all that. So what we did is, we said that, okay, is there a way by which we can get an image quality which is good enough for a doctor or an ophthalmologist to grade this? And then that's the thing which we improved, and we got a device called Trinetra, which can do all these, in one. All this in one, and cost a fraction of all these put together. So if all these put together is around 30-40 lakhs, this is around 5 lakhs. So that sort of a thing. And more than anything, you want to take this to the field. If you want to take this to the field, there is no power, in all these villages. So we had to see how we can do that. So we reduced the power consumption to almost 1/100th, I would say. It just consumes 6 watt power. 6 watt. So a slate-sized solar panel is enough to energize this. So with that, we are in a position to go take this to wherever we want, and then, screen people out there. And you can now screen them for all these eye ailments, and it can be operated by a minimally trained technician. So we train drivers, unemployed graduates and all that to do this, and through telemedicine, they are in a position to contact the base hospital and get the report from them. So with this paradigm change, we see that today we have this Trinetra, which is deployed in different type of setting. We have this in optical stores. Basically, in optical store, they have one autorefractor, and then most of the time, it may not be very good if you just look at the refractive error and give a spectacle. The refractive error is only an end consequence of any sort of a vision problem. Okay, it's a vision loss is the end consequence. It may be due to diabetic retina, it may be due to glaucoma, it may be due to some sort of a mild cataract also. So you have to rule out all that before you can say that this is only a refractive error. And for that correction, I gave a spectacle. If somebody has a glaucoma, you just do the test and you get some refractive error. Then next day morning, when the person gets back to the normal pressure, then this spectacle won't work. Okay, so that sort of very serious problems you will get into. So nowadays, optical chains, they use our device and they do a comprehensive check. And in the process, they also give a benefit to the user that if they have other problems, corneal problems, like glaucoma or diabetic retina, then they refer them to the right type of doctors. Then we have this in government schools and all that, NGOs, mobile units. We have created not only a van on which we have this device. We also have on mobiles, we have this device. And in Mumbai, 7 slums, we have our bike version of Trinetra, which goes into the small gullies of all these Mumbai slums, and we screen people there. And then, we have medical camps. Nowadays, we have a lot of medical camps. Earlier, for a medical camp, there used to be at least 2 to 3 ophthalmologists and 6 nurses, paramedics, and all would go to the camp. Now, one single person, trained technician can go and do the same sort of a clinical outcome, 200 to 250 people in the camp. And then we also have GP office models, and we also do that in diabetic centers. Diabetic centers are one place where we see that there is a big demand for such a device, because in a diabetic center there are a lot of people who come for diabetes, and then they one of the tests which they can't do there is used to be the eye test. So they had to send them to the ophthalmologist. Whereas with this device, instead of sending the patient to the ophthalmologist, they send their images to the ophthalmologist, and by the time the other tests are over, the report has come. So that sort of a thing. So there is these sort of other benefits what you get. That is the thing what we see. So today, from a simple Trinetra Classic, which was our entry-level product, now we have Trinetra Royal, which has additional features where auto-ref also is built into this device. This is the first of its kind in the world where even auto-refraction is done in a single fundus camera. Okay. And then we have Trinetra Flora, where fluorescence angio can be done. And then there is a Trinetra Kiddo, which is basically for school children screening. This is a very wonderful device for school children or children below, say, the age of 5 years, say 3 to 8 years. We can do screening with this. This not only gives just refractive errors, it also gives you the squint angle, lazy eye, all these sort of problems, which are very, very easily curable if you detect at that stage. So that is the thing what we do with Kiddo. And then we have Neo, which is basically a retinopathy of prematurity. This is for the premature babies. This is something, which we are really proud of to say. There is only one company in the world which used to make such a device, and that costs around $130,000. That's the entry price. We have put in a device now into the market, which is as good as that, and it just costs $20,000. So that is the thing. And in India, of course, premature babies, we have more than 4 million, that is 40 lakh premature births happening every year. And all these kids, have to be screened within the first 5-6 days. 5-6 days for ROP. And if you miss them, then, they can go blind in the next 6 to 8 weeks. So we in India have a very big problem that way. And we see that more than 2 to 3 lakh blind kids are put into the society every year just because of ROP problem. So this is a device which we have made, which can really, really help in detecting these problems. So as I was telling you, for disruptive innovation, it is not just making the device. We need to have a complete ecosystem. And that's where, we have made this telemedicine package. This is a telemedicine system where it's the entire thing, the device is in these rural centers, and then there is a triaging software which will actually decide, which will classify and say whether there is a problem or no problem, and if there is a problem, is it a problem related to only refractive errors? Yeah. And then, we created such a system. Now we have deployments of different type. This is one in the diabetic centers. This is a complete package what we give. where we connect the nearby ophthalmology center to this screening center. This is the school screening thing what we have. These are all complete packages, as I. And then also, all these things, they are connected to our forest cloud, Trinetra cloud, which takes care of the entire provisioning. So this is the affordability what we talk about, and you can see since 2010 we have come a long way. And then once you screen more people, what the next thing what you see is you need to treat them, and that's where we are also developing our own treatment devices like the laser. We have photocoagulators, LED based photocoagulators, and image guided therapy, all these sort of things. And then we see that going forward you might have to also maybe move some of the diagnosis to the field. So that is what we are getting ready for. So with that, today we have more than 800 installations in 20 countries, and we have touched more than 1.2 million people. So this is what I wanted to share with you.
Amazing, Sham. Long journey, yeah? And I think has been well recognized also. I noticed Hillary Clinton there in your pictures out there, appreciating it. Well, maybe a message to a lot of Indian innovators that, a product, a world-class product, need not necessarily have to take birth anywhere else, but in our own backyards. And I would like to call upon another. I would like to apologize on behalf of Rahul. He was last seen, going to Kerala for his honor sadhya, and then after that, I never heard from him. So, unfortunately, we don't have him here. So, Rahul, we were looking forward to having him here because he'd just been, selected. I mean, he had been selected, voted, felicitated as the top 30 innovators under 35 across the world by MIT. A very nifty innovation that was so simple that could keep a baby alive and warm with a very simple physical phenomenon called phase change materials. And this is nothing but a material that once you heat up, it would retain this heat and slowly release it so that a baby could be kept warm without electricity, without any other external kind of element for a period of 8 hours. The mother would be free to do other things rather than, use a kangaroo mode of holding the baby. Fortunately, we couldn't have him here today. I hope all is well with him because honor sadhyas can be treacherous. We would like to call on Samir. Samir has been practicing and a practitioner of telemedicine now for over 10 years? Or was it 8 years? More than that. From the point of view of what we've been talking of all these days and probably all these years about the effectiveness of telemedicine, quietly in the background, Samir has been actually applying it. Currently, he covers 8,000 rural villages in Bihar, and probably works very closely and has an ambitious plan to cover 35,000 villages and connect them up to be able to deliver primary care in these 35,000 centers. He works in partnership with World Health Partners, and this modality has withstood the test of time. His claim to fame is that with a very, very narrow bandwidth, he's been able to conduct both video conferencing and vital signs monitoring over the network. Over to you, Samir.
Thank you, Vijay. Good evening to all the friends here. Probably I'll just start by saying that the work has mostly been under the radar, except for recognition of some specific awards and so on. So it's my honor to present here in front of you. It has been a long journey, so it might also touch upon various points which today may not seem as innovative as they were when they were actually started. But this actually also talks about a journey which had various phases, which where we had to undergo various tests. of sustaining and going forward from the point where we were, and it indicated changes in the direction, changes in the way we thought, and so probably I would still go through explaining some of those. So this probably is known to all of the people present here. The challenges in the primary healthcare. We have most of the population as rural, living in a little difficult to access kind of areas, over 70% of the population. Who can access have much more cost to that access, and there is a lack of qualified medical professional all over through the not only in the rural but also in the urban and at all levels, right from the health workers to the specialists. Healthcare expense pushes a lot of millions of people and families below the poverty line every year. So the talk about the GDP driver, healthcare being the GDP driver, is really, really true. It can save a lot of, and it can generate a lot of wealth for the country. And most expenses are out of pocket, which means the financial mechanisms are really lacking there. And now that it is already well established, the non-communicable diseases have taken a large share of this. And so we are sitting on sort of a time bomb, which is ready to explode anytime unless we do something. So this was something that we recognized quite some time back, and we believed that technology solutions are the ones which can actually address this challenge very, very well. It's just probably that we started very naive. But anyway, so basically the mission statement of Neurosynaptic, we set out for enabling access to quality and affordable healthcare to masses in the rural areas through technology. That's the mission statement. About Neurosynaptic, we are the largest telemedicine solution provider today. We are an ISO 13485 and ISO 9001 certified processes company, IEC 60601 certified products, and very clinically validated products. We have basically enabled last mile healthcare delivery through indigenously developed and patented telemedicine solution called Remedy, which connects the entire ecosystem right from the health worker to the specialist at various layers where these solutions and these providers are present. And of course, we are a DSI recognized R&D lab, and we have been supported by the Technology Development Board. We have over 2,000 rural installations. These are just the centers, and as Mr. Vijay has also mentioned, about 8,000 health workers today using this technological solution in the states of UP and Bihar. And we also, not only in India, but also have presence in some of the Southeast Asian countries as well. Typically to note, Myanmar, Philippines, Bangladesh. Bangladesh is where we have the second largest installation base, and Kenya and Senegal, as far as Senegal in Africa. So this is something that has scaled also beyond India in its course of time. This was the basic starting point, and we were very naive to think initially that once we develop this technology, the problem will be solved, because that was sort of the initial plan. We take this solution, put up in the operators in those village centers where typically there is a kiosk which is operated by a worker who is not necessarily a health worker, and at the back end connect them to some doctor who is in that region, and the problem is very easily solved, QED. So, so that was the very naive thought process initially when we started. We started about 12, 13 years ago. This was quickly developed. We put it in the field, and that is when the real journey started. We basically initially put this in the village health centers, connected them directly to the doctor. So what you see on the left side is the device that was put on the three images and the central image. Central image is the doctor's kiosk from where they would provide these consultations. Now there were many innovative components in this, which I still don't see a match in the world, which was developed that long ago. For example, a video audio conferencing that works on as low as 32 kilobits per second. I have not seen it yet. It works on a simple telephone line modem. You just plug it in with a BSNL connectivity, typically supported by the USOF, which is 150 rupees a month, available in the rural areas where it is available, and it starts working. So that is the beauty of this solution. It has a whole comprehensive medical record which was developed in course of time. And we put it between the village centers and the general practitioners. This was way back in 2005-6 when we deployed our first center, and it was a disaster. Why it was a disaster is basically what it appears very easy today to understand is that there was no pharmacy in the village, and even though the doctor would prescribe something, it would not work because the patient would still have to go far away and pick up the medicines. Unfortunately, that still remains a challenge today, and it has gone into some standard operating procedures which will still identify how that medicine can finally reach to the place where consultation is provided. And I think we need some work around regulations to be able to get that done. But so that's one challenge, and though there were similar challenges all over the place in terms of the whole ecosystem. The first thing that we recognized was the broken ecosystem. What we thought would be a natural ground for just deploying this technology simply did not exist. So we said, okay, our commitment is to solving this issue rather than just the business for business sake. So we'll continue this. So in the next 3 years of journey, we basically we had initially started in Tamil Nadu, which was a little well off in infrastructure. Then we went all over from the southern states to the central states, Andhra Pradesh, Maharashtra, then came up in Madhya Pradesh, Bihar, UP, Bengal, Tripura, as far as Tripura, to understand dynamics of the business in this whole game. What solutions would work, what business models would work, what all would really make sense in this scenario. And the platform slowly evolved. Platform became what it is today in this due course of 3 or 4 years understanding. It basically captures now multiple entities which are involved in the healthcare delivery, right? Not only the village health workers, but the centers, the hospitals, the doctors who would be available anywhere, the pharmacies, the diagnostic labs, and all of the healthcare deliveries. The two things that are not sort of shown here are the payment gateway and insurance, which also are now today the part of the platform in some sense or the other, because they have been more recently introduced. So it has been an evolving journey. A little, and I would like to go back to Mr. Vishal's comment here. The whole game is in trying to simplify the complexity. So I'll first try to explain the whole complex structure that we had initially developed initial days. This is a typical business structure. I use it from the World Health Partners, with whom we have developed this together. Yeah, so basically, it starts with the village health worker who is typically operating in the villages, who is the current care provider of these villages. It could very well be ASHA worker. It could very well be any of the entities who is involved in these activities. Maybe partially qualified or a little less qualified, more qualified, various grade. They can do some very basic things. They can carry a mobile phone. They can enable a consultation, a voice-based consultation, because we don't still have bandwidths in the villages. We're talking of villages of 1,000 population, 2,000 population, even smaller, sometimes bigger. Then you have the next layer, which is basically a stationary telemedicine center, which typically has a computer and a range of diagnostics, a little wider range of diagnostics, which includes physiology, which includes chemistry today, which includes some of the scopes, which will give you images, which will give you eye images, skin images, and various other things. We have over that layer about 1/5 in numbers the qualified GPs who have existing clinics in these areas, and also diagnostic labs which are already existing. So all of this is almost an existing infrastructure, except the central medical facility, which is more like a call center of the doctors, paramedics, who continuously work with these operators, center operators, keeping on taking the case sheets of the patients and trying to consult them through either the audio call or a video audio consultation, transferring the calls to the required specialty if that is the requirement of it. And then a whole supply chain of medicines built to the last mile with the help of technology. So the sales guys go with the point of care solution and distribute these medicines to the pharmacy plus kirana shops which you get in these areas typically, while the doctors at the back end know exactly what medicines are available near which which of the centers to be able to prescribe them correctly. Very nice, interesting things about this. The medicines are numbered so that there are no mistakes in issuing them. Even with the new alphanumeric literacy, the numeric literacy is much better in the villages. So this entire structure was set up starting 2008 and has scaled to about 2,000 centers now all over. So the impact that we have received, how much time do I have? 2 minutes, okay. So the impact basically that we have achieved is about 2,000 centers, 8,000 health workers, 50 million population is covered in 30 districts, 10 states. Most deployment is in 2 states of Bihar and UP, which are fairly in need of this solution. About 75% of patients needs addressed within their villages. They don't have to go far from their village. About 40% of the people any day visiting the centers are somebody who has accessed it prior, which means there is a very good acceptability of this. And the consultations minimum cost about 50 rupees, which includes various diagnostics, including ECG. So this is something that is very nicely worked. It is not 100% financially sustainable at this stage. We still have, in some cases, grants or donations supporting it. But there are other models. This is the most probably complex structure that I explained. There are simpler models which have been used by, let's say, Meenakshi Mission Hospital and various other hospitals, hub and spoke kind of models, where even 20 rupees are charged and the centers are still sustainable with the population of the patients visiting them. And accessibility we have brought down, which is about 4 kilometers, better compared to the primary healthcare centers in these areas. So a very, very significant, and there are tens of lakhs of patients who have actually paid for the consultations and then accessed this care and come back or gone to the next levels of care in the network. Yeah, this is not going ahead. Yeah, so this is a new recent introduction. Which is a mobile-based technology. There are about 400 health workers at this point of time out of that 8,000 who are taking this. It provides 35 diagnostic tests, including the blood tests, the malaria, dengue, chikungunya, hepatitis, whole range. It can provide HIV also, but we are not yet introducing it because of some reasons, regulatory reasons. It weighs less than 2.5 kgs. It also provides the urine tests, etc., along with it. It works on Android-based tablets, and there is a nice bag which you can see at the bottom picture there, which is sort of a laptop kind of bag which can be carried along. And more diagnostics are coming up. So journey basically I already explained. I don't need to go in this. This is our PR engine. This is somewhere that has kept us sort of known in the community. Right from the Technology Pioneer Award by the World Economic Forum way back in 2008 to the latest NASSCOM and the ASME awards that we have received last year and this year. And in the middle, the Social Entrepreneur of the Year, we were the runners up there, and Action for India, which said we are the fastest growing healthcare enterprise in the social enterprise category. We are a part of Ashoka Networks. We are supported by Grand Challenges Canada in this endeavor. Basically, most of the research and development happens on the grants. Some new initiatives, many more diagnostics at the point of care, entirely new global expansion model. So watch out in the next 3 or 4 months. There is a completely retail model coming out, which will be a parallel network to the government. And and the new product initiatives in the other segments, we are also working on tele-ICU with in partnership with One Breath here. And so a couple of more initiatives are also on the roll. So I'll leave this for, basically there are some suggestions on what can enable this disruptive ecosystem, innovation ecosystem. Yeah. We basically look for... Yeah.
I think we've given you 10 minutes more for the kind of impact that you have shown.
Sure.
For every 1,000 patients that you have impacted, we've given you 1 minute. So we'll give you another 1 hour. We'll look forward to that.
Thank you so much.
Thanks, Samir. Yes. I mean, it's amazing, the impact story. I mean, I don't have one to tell, so I respect him for that.